On behalf of Region 7 and the ASPR Supplemental Grant, we want to invite you to listen to our series of Zoomcasts. These conversations are meant to inform and educate our listeners on the perils and pearls of the lessons we have learned regarding COVID-19 and other special pathogens. We will be having conversations with experts in their field and sharing the information with you. So listen, learn, and enjoy the following Zoomcast.
Hello, and welcome to this episode of our Region 7 Zoomcast. I'm Shanaz Benner, and I'm one of the clinical program coordinators for a biocontainment unit, and I'm happy to talk with Dr. Ted Cieslak about Nipah virus. So tell me a little bit about you, Ted. Where have you worked? What's your expertise in? And what do you know about Nipah?
Well, thanks, Shanaz. It's great to see you again. As you know, and as I'll tell the audience now, I'm a pediatrician and infectious disease physician. I spent 30 years on active duty with the Army. During my Army career, I spent many years at USAMRIID, at the U.S. Army's Medical Research Institute of Infectious Diseases at Fort Detrick, Maryland. And I also spent several years as the military's liaison officer to the Centers for Disease Control. And in any case, I retired from the Army in 2015 and took a job at the University of Nebraska and got to work with you and the great folks in our biocontainment unit and quarantine unit. And then I finally retired from that job this past summer, but I'm sticking around like a bad penny, won't go away, and doing some part-time work for the university.
Hey, we will take you any day, Ted.
Well,
so what is Nipah virus, and what should I be concerned about if it reached into the United States?
Okay, so Nipah is on the one hand, fascinating, and on the other hand, pretty frightening virus. It was first discovered in 1998 when an outbreak occurred in Malaysia. And a lot of credit goes to the epidemiologists who figured this out, because the epidemiology of Nipah virus is pretty complicated, but basically here it is. So you're all familiar with the fact that climate change has been a big problem. That's true in Malaysia as well as in the rest of the world. There's also a lot of deforestation going on in the jungles of Malaysia. And so it's thought that fruit bats who had previously resided in those jungles, when the jungles started to be cut down, had to move into nearby orchards. And in Malaysia, it was traditional to raise pigs in orchards, and it was kind of seen as a win-win situation by Malaysian farmers. So the pigs would feed on the rotting fruit that would drop off of fruit trees, and in turn, the pigs would fertilize the ground for the benefit of those fruit trees. And when these bats moved in, these flying foxes of the genus Pterapus, we now know that those bats carry the Nipah virus. They seem to be the reservoir, and their droppings apparently contaminate the fruit on the ground, and the pigs eat that fruit and they contract the disease. Pigs usually have very mild disease, but then humans got the disease from those pigs. So it took a lot of good gumshoe epidemiology to figure that out, but kudos to the epidemiologists who figured it out. Then a few years later, in 2001, I believe, the first Nipah virus outbreak occurred in Bangladesh. And Bangladesh is a majority Muslim country, so they don't raise a lot of pigs there. And so that raised the question, well, what's going on there? And it turns out that they don't raise too many pigs, but what they do is they harvest raw date palm sap. And so they'll climb the date palm trees and put a bucket in there and collect the date palm sap. And it turns out the bats were urinating and defecating into the date palm, and people would sometimes consume that sap raw, and they contracted Nipah virus that way. So again, fascinating epidemiology. While the epidemiology is fascinating, the disease is pretty frightening. So this is a disease that's transmitted by the respiratory route. And let me back up a little bit. This disease, this virus, Nipah virus, is a member of the paramyxovirus family, and that's the same family that includes measles and mumps. And those are both transmitted via the respiratory route. And Nipah is no different. It can be transmitted by the respiratory route as well, although it can also be acquired apparently by eating, again, this raw date palm sap or other things containing the virus. So this is in large part a respiratorily transmitted virus. You can contract it from a person who has it via the respiratory route, via respiratory droplets. But there are other ways to acquire it, as we've already said. And it can produce respiratory symptoms. You can get respiratory distress from this. But what's somewhat unique about it is it also produces an encephalitis. And in fact, that's what it's known for. So this somewhat unique combination of encephalitic symptoms and respiratory symptoms is what characterizes Nipah virus infection.
Okay, thank you for that, Ted. Where did the name Nipah originate from?
So there, I think, is a little town somewhere in Malaysia called Nipah, and that the first cases were reported from that region, and that's where the name came from.
All right, thank you. What type of exposure is needed to transmit it other than, the date palms and the other things that you mentioned? Are there any other things that we don't know about?
Well, like I said, the epidemiology is fascinating, and I'm not sure we know everything there is to know about it yet. If you look at the situation in Malaysia, again, most of the people who acquired the disease there acquired it directly from pigs. So the pigs would get disease. Again, they usually didn't get very severe symptoms. In fact, what I've heard from people in the know is that often those pigs were so healthy looking that the farmer had no clue that they were even sick, and the farmer interacts with the pig and contracted the Nipah directly from the pig. I don't believe there was any evidence of person-to-person transmission in that Malaysian outbreak. But the story was very different in subsequent outbreaks in Bangladesh and India, where there was significant person-to-person spread and nosocomial spread. And when there is person-to-person spread, it's usually via respiratory droplets. So for people like you and I who work in biocontainment settings, or for that matter, for anyone who works in a hospital setting caring for other patients, the thing we need to worry about is predominantly that person-to-person spread, that nosocomial spread. Hopefully none of us are going to be consuming raw date palm sap anytime soon.
I know I won't be. What is the incubation period after an exposure to Nipah?
Yeah, so it's thought to be somewhere between 5 and 14 days. And after that incubation period passes, patients generally develop a fever and headache. And so those are the early signs. And then very quickly moves into an encephalitic picture. So you get drowsy. Some patients actually lapse into coma. You begin to develop neurologic findings. And again, you also may develop respiratory distress. So Nipah's not too many viruses that cause both of those syndromes, that cause a respiratory syndrome as well as an encephalitic syndrome. And that unusual combination is what should point you to think about things like Nipah. And so the mortality rate of this disease is pretty horrific. In the Malaysian outbreak, it was close to 40%. I think 39% of people succumbed to it. And when you do die of it, you can die in one of a couple of ways. You can die of coma and neurologic problems, or you can die of respiratory distress syndrome. And unfortunately, even many of the survivors are left with long-term neurologic disabilities.
Okay, thank you for that, Ted. Very interesting. So in other words, what you're saying is that it's highly contagious.
Yeah, and so, when we evaluate diseases and try to make a determination as to whether they should be managed in these specialized biocontainment units like we have here at Nebraska. We look at several criteria. So we look at how infectious is the agent, and we don't have good data as to the infectivity of Nipah. We know it's infectious. Exactly how infectious we could argue about. We want to know if it's contagious, and we measure contagion in terms of the R naught. You may have heard a lot about R naught as it's applied to the COVID pandemic. So the R naught for Nipah is greater than 1. It can be the cause of an epidemic, as we've seen already in Bangladesh and in Malaysia. It is probably not as high as many other diseases that we deal with, but it is contagious. So the disease is infectious, it is contagious, and with a 40% mortality rate, it's pretty darn hazardous. So it meets those first 3 criteria. And then the 4th criteria we apply is, are there licensed medical countermeasures available to protect our hospital staff against it? And the answer in this case is no. There's no licensed vaccine. There are no licensed therapeutics. So I would argue this disease meets all the criteria for high-level containment care. And if we had a case here in Nebraska, we would probably manage that patient in the biocontainment unit. Does that mean you couldn't manage them in a more conventional setting? No. And that's been done, obviously, in Bangladesh and India and Malaysia. But I would argue patients have also been managed unsuccessfully in conventional settings as well. So given that we have the luxury of our biocontainment unit, I think this disease would be a good candidate for biocontainment care.
All right, thanks, Ted. So Ted, with all of the other highly infectious communicable diseases out there, what would differentiate Nipah from any of those other ones? Is it travel origins? Is it the transmission? What is it?
Now, that's a great question, Shanaz. So right now, we are only aware of Nipah cases being present in these few localized areas, in Malaysia and Singapore, and in Bangladesh and India. So the way it stands now, a travel history to one of those areas would be a critical piece of the epidemiologic puzzle if you were suspecting Nipah. Now, to back up a little bit, I would suspect Nipah, or at least I hope I would, when I saw a patient with that unusual combination of both respiratory and neurologic symptoms. So if I had that constellation of symptoms, I would hopefully take a travel history. If the patient had been in Singapore, Malaysia, Bangladesh, or India, then I would hopefully be strongly suspecting possible Nipah virus infection. Now, the problem is that this virus, again, we know its primary reservoir is the Pteropus genus of bats. These are the flying foxes of fruit-eating bats. And those bats are ubiquitous throughout the world. So we have those bats in the United States. We don't have the Nipah virus yet. But what some of us worry about is that, other areas of the world are certainly ripe for that virus moving in. And so far it hasn't, but let's hope our luck holds out in that regard.
Thanks, Ted. So how is a person tested for it? Is it a blood sample? Is it a PCR test? And what's being done to run these tests?
Yeah, I am not the expert at laboratory science, Shanaz, but I do know that there are PCR primers available. And so the diagnosis would typically be made by PCR. That could be done on blood. I believe it could be done on spinal fluid as well. There also are antibody based tests that can look for this virus. They're obviously not going to be widely available. And so if you do suspect Nipah, then you ought to be working closely with your laboratory. We have the luxury here at Nebraska of having the Nebraska Public Health Lab on our campus, and they work closely with the CDC and USAMRIID and other state-of-the-art diagnostic laboratories who do possess these primers. And these antibodies. But if you're most hospitals throughout the country, you're not going to have these in your laboratory. And so when you start suspecting this, you need to start coordinating with public health officials. I would caution that this is a BSL-4 pathogen. And so you should not be attempting to isolate this virus unless you have a BSL-4 laboratory.
Interesting. So are there any other populations that are more at risk that they've seen in data for populations, elderly, young, pregnant, women?
Yeah, and that's a good question, Shanaz. And the answer is I don't know. For most diseases, people at ends of the age spectrum, the very young and the very old, are at increased risk. I think the numbers of cases that we've dealt with in terms of this virus are probably not enough for us to make definitive conclusions. And keep in mind that most transmission of this disease, of Nipah virus, in the past has occurred in one of a few ways. It's either close contact with pigs, which would mean you are a pig farmer, or it would mean nosocomial transmission, which means you work in a hospital. So obviously not a lot of young children or very elderly people farming pigs or working in hospitals. And that skews our understanding of the epidemiology. But it wouldn't surprise me if the very young and the very old were at higher risk for severe disease.
So you would mention that Nipah has the dual combination of respiratory and also neurologic symptoms. Which one would be seen first, or is it interchangeable?
Yeah, I think that's a good question too. I think, the hallmark finding in this disease is the encephalitis. And typically the earliest symptoms that patients present with are fever and headache. So, it's not every patient who goes on to develop respiratory symptoms. In fact, in the Malaysian outbreak, very few people developed respiratory problems. Most of them just had encephalitis, whereas in the Bangladeshi outbreaks, a higher proportion had both encephalitis and respiratory findings.
Okay. How rapid do the symptoms progress once they've caught or transmitted the virus?
Yeah, they progress pretty rapidly. So again, there's an incubation period of 5 to 14 days. And once you do start developing symptoms, those symptoms can progress from headache to coma over the course of a few days. And then obviously patients go one way or another. They continue their downhill spiral. And again, death occurs in close to 40% of them. On the other hand, if you start to recover, the recovery can be pretty slow. And there are reports of people with permanent neurologic disabilities, and there are reports of people who took months to overcome their headaches and their confusion and their personality changes.
So similar to COVID, where we've been seeing people with long COVID down the line and some permanent disabilities associated with that.
Right. Yeah, I think there's a lot we don't know about both viruses, about Nipah and COVID, and I'm sure we'll learn more the hard way over the coming months and years.
Have they seen anybody that had Nipah that had no symptoms or not shedding the virus, essentially?
Yeah, that's a good question. We know that there are pigs who have virtually no symptoms. In humans, I'm not aware. I don't have the data at my fingertips. I don't know if significant serosurveys have been conducted. I suspect they have, but yeah, I don't know what percentage of persons have asymptomatic infection.
So do we know if the person is more contagious before or after symptom onset?
Well, this is not one of the diseases where patients can transmit before they themselves are symptomatic. The good news in infection control is that the number of diseases for which that does happen is very limited. COVID is one of those few where you can actually transmit disease before you yourself know that you're even sick in the first place. Influenza is another one, measles. and chicken pox, and that's about it. But Nipah does not fall into that category. So we believe, again, based on limited experience, that you can't transmit Nipah virus to someone else until you yourself have become symptomatic.
All right, thanks for that, Ted. So we're going to transition a little different direction. So as a healthcare provider, what would I want to expect to wear taking care of a patient with Nipah?
Right. So this disease is spread by respiratory droplets. So those are particles that are generated when you cough or sneeze. We're not aware that it's transmitted by droplet nuclei that, can be breathed out in essence. And so if you trust your infection control capabilities, you ought to be able to use droplet precautions. And droplet precautions would include, obviously, as you know better than I do, a surgical mask, and that's about it. And of course, the gowns and gloves and common sense sorts of things that we always do. So droplet precautions is the textbook answer. On the other hand, we've been talking earlier about this is a candidate for biocontainment care. It's fortunately a very rare disease heretofore. We fortunately haven't had to have much experience with it in this country. And if we did get a patient in our biocontainment unit, I would probably want to opt for extra protection, like at least a face shield, maybe a PAPR, but the textbook answer is droplet precautions.
All right, thank you, Ted. So what types of treatment would be ordered for this patient?
Yeah, so right now there are no licensed specific countermeasures. There's no licensed vaccine, and there are no licensed therapeutics. So the mainstay of care, and I suspect it would be the mainstay even if there were licensed therapeutics, is supportive. So if these patients get hypoxemic, we give them oxygen. If they can't drink, we give them fluids. We support them through their illness, and that's, again, the mainstay of care. There are obviously several things that have been looked at. Ribavirin raises its head every time we have some new virus and we don't have anything else. Somebody gets the idea to, let's look at ribavirin. Ribavirin looks good in the test tube. It has looked good in some animal models. It'll remain to be seen whether it really makes a difference. No controlled clinical trial of ribavirin has been conducted. Another thing that gets mentioned every time some new virus rears its head is convalescent serum. Could we take convalescent serum from someone who's recovered and use that to treat other patients? There's some problems with that. It sounds good. And we've done that for some other diseases in certain circumstances. But the problem is, first of all, the results with many other diseases have been less than impressive. Second of all, it seems to take quite a while for sufficient antibody levels to appear after a Nipah virus infection. And so, picking the right donor gets to be very, very difficult. And again, there's been no head-to-head clinical trials to support that. And then some monoclonal antibodies are in development, but again, none of those have been licensed as of yet.
All right, thank you, Ted. So Ted, is the waste considered hazardous, and how should it be handled?
Yes, that's a good question, Shanaz. So this is, according to the Department of Transportation, a Category A infectious substance. And so the waste emanating from a patient with Nipah virus infection would be considered a Category A infectious substance. And as we said earlier, this is also a BSL-4 pathogen. So handling it in the laboratory should be done only if you have BSL-4 capability.
All right, thanks, Ted. So if I was in an emergency room in the United States, what things should just catch my eye on this, especially with me working in an emergency room as well? I see somebody with headache, fever, maybe possibly a cough, and then I look into travel history, and that should just automatically just flag that person?
I think unfortunately you've got it. When these patients aren't going to have much to look at, they don't generally have much in the way of a rash or anything, that's readily obvious to the unaided eye. But they're going to have this combination, and again, keep in mind, not everybody has respiratory symptoms, but if you have a patient with encephalitic symptoms, especially if they also have respiratory symptoms, then that should prompt you to, ask a few questions. And, as an infectious disease doctor, we think everybody should benefit from a travel history. But in this case, especially, you'd want to ask a few basic travel questions. Where have you been? And if the answer to that is Singapore, Malaysia, Bangladesh, or India, then yes, that ought to raise a big red flag in your mind. And, unfortunately, I'm not sure there's a lot you're going to do in the emergency room beyond that that's going to tip you off. Any confirmation is going to require sophisticated, laboratory studies and stuff.
All right. Well, thank you, Ted, for this discussion and informing us on Nipah virus. I think that I feel a lot more educated about Nipah, and I think that other people would get a beneficial sense from this discussion. So thank you, Ted.
Well, thanks, Shanaz. Yeah, it's great to be back among friends and talking to you, and hope you enjoyed the talk.
Absolutely.
Hope it's information you'll never need to use.
Right. Thanks, Ted.